Welcome, everyone. Just going to give a few minutes for people to continue to log in, and then we'll get started. Thank you, everyone, for joining us for our MCPAP for Moms webinar series that takes place quarterly. My name is Beth McGinn. I am the manager of MCPAP for Moms, and I am here to present today's topic, the perinatal mental health and substance use, an overview of assessment and treatment. Just a few housekeeping items. The session will be recorded and available on our website at mcpapformoms.org. A copy of the PowerPoint slides will also be available on our website, and you can find that under the toolkits and resources under presentations. Our presenter will stop for questions at several points during the presentation, and there'll be time at the end. If you have a question or comment, please type your question into the question box, and we will be happy to read that out or unmute your line so you can ask your question. You'll be asked at the very end to take a very brief survey. And we always appreciate your feedback for us to help us improve for future presentations. And I would like to introduce our distinguished presenter, our very own Dr. Leena Mittal. Dr. Mittal is serves as the Medical Director of Equity and Innovation for MCPAP for Moms. She's also a board certified in psychiatry and psychosomatic medicine and addiction. She's also sits on several chairs, the associate chair for diversity, equity, and inclusion. She is the chief of division of women's mental health at the Department of Psychiatry at Brigham and Women's Hospital. Additionally, she serves as program director to the Women's Mental Health Fellowship at Brigham and co-chairs the Justice, Equity, Diversity, and Inclusion Committee. So without further ado, I will hand things off to Dr. Mittal.
Thank you so much, Beth. I'm just trying to adjust my window here. I'm not that comfortable with Teams. I hope I don't accidentally leave the meeting by trying to do this. Let's see. Sorry, I can't see my slides now somehow, but I've just changed my view. I know I can't see my own slides.
Yeah, and we no longer can see them as well.
Oh, okay.
It's just a black screen.
Sorry, everyone, for my technical difficulties. I'm not Teams savvy. Okay, I'm just going to stop sharing again and then see if I can reshare. Okay. And then Beth, I just want to make sure we're recording.
Yes.
Okay, perfect. All right. Is the sharing functional now?
Yes, we can see your slides now.
Okay, thank you. Sorry about the delay, everyone. Thanks again, Beth, for the lovely introduction, and thank you all for coming to this webinar. I hope today to sort of do a whirlwind tour of perinatal mental health and substance use, just kind of an overview of assessment and treatment, and to talk a little bit about how MCPAP for moms can help. So we'll start with just talking sort of broadly about background around mental health and substance use in pregnancy and among perinatal individuals. We'll talk a little more specifically about perinatal depression, anxiety, and bipolar disorder, then shift to a sort of brief overview with some updates on perinatal substance use, especially some things that are happening here in Massachusetts, and then tell you just a little bit, just remind you all how to use our services and how we're here to help all of you working with perinatal individuals. So just by way of scope, perinatal depression is one of the most common complications of pregnancy. It affects as many as 1 in 7 women, but with estimates that sort of look at more specific populations, it can be as high as 1 in 5, even as high as 30 or 40% of populations, depending on kind of the unique characteristics of those studies. And so this is to sort of scope it, it is more common than many other complications of pregnancy. It is widely common in our perinatal population, and it's something that we all have a role in addressing. Perinatal emotional complications broadly can be associated with many conditions and diagnoses. So depression, anxiety, OCD, post-traumatic stress disorder, bipolar disorder, psychosis. So when we're talking about emotional complications, we're often talking about depression, which is the most common, but emotional complications can actually really occur in the context of a variety of formal diagnoses, and perhaps even outside of formal diagnoses. When we're thinking about kind of the impact of mental health symptoms, we're really talking about a transgenerational impact. We're talking about an impact on the birthing individual. We're talking about impact on the child who is born, and then the larger family structure. Individuals who have mental health symptoms are demonstrated to have less engagement in medical care. So, for example, attending fewer prenatal care visits, being at risk for smoking or substance use, being at risk for obstetric complications like preeclampsia or preterm delivery, lower birth weight, NICU admissions, lactation challenges and bonding issues, adverse partner relationships, tragically, suicide, which is a growing cause of maternal mortality in our country. And then for the child, cognitive delays, motor and growth issues, behavioral problems, mental health disorders. So these are not benign impacts. And as I sort of referenced earlier, mental health conditions are now the leading cause of pregnancy-related deaths in this most recent report around findings of maternal mortality review committees across our country in about 36 states. I have the honor and privilege of sitting on the maternal mortality review committee for our state, and can attest to the fact that we, over the course of my time on the committee, have seen an enormous impact of mental health conditions, which are inclusive of causes of death related to suicide, overdose, intentional or unintentional, or have a mental health or substance use diagnosis listed as a contributing factor. And so to transition a little bit to thinking about the impact of substance use kind of alongside mental health, because it's not often easy to disentangle the two, as much as our healthcare system may try to. Substance use for a perinatal individual can pose impacts to that individual themselves, but also to the fetus and pregnancy and to the family. So we think about exposure to teratogens, meaning some substances that are used as part of use disorders or use patterns are teratogenic, meaning they can cause birth defects. Again, individuals with substance use present to fewer prenatal care visits. They're at risk for poor nutrition, placental alterations in functioning, challenges with labor management, the impact of withdrawal from the substances they may be using or are dependent on, overdose, which can be fatal or can also cause health-related issues for both the individual, the pregnancy, and certainly the family impacted. And then infectious risk. So substance use increases risk for transmission of infection, both to the individual and then from the individual who's pregnant to potentially the fetus as well. And again, we think about the driver of substance use as a driver of maternal and infant mortality, but most importantly, and I'll underscore this later as well, a preventable cause of mortality. And then as we're thinking about mental health and substance use, we also have to think about the impact on parenting. Issues around custody can impact, sort of a bi-directional impact on mental health and substance use disorders. Individuals with diagnoses or with mental health needs and substance use diagnoses or engagement and treatment often are reported to social services, DCF in our state. There's an increase in scrutiny in this process for individuals who are affected by poverty and for individuals and families of color. And then there's also the sort of other direction of impact that losing custody, being engaged in a system of child welfare actually can have an exacerbating impact on mental health and substance use disorders as well. And so we see this in so many different contexts, including, for example, I will say in the maternal mortality review committee process, we see the impact of engagement in the child welfare system and impact on individuals with substance use disorders there. And so all of this is sort of to say that while we're often talking about individuals who are pregnant here at MCPAP for Moms, we like to think about the role that we all can have in trying to plan or engage in a process of reproductive life planning. Preconception planning is critical. So if somebody is thinking about attempting to conceive or become pregnant in the future, it's really important to think about the risk of the impact of the stress of the attempt to become pregnant, and also to think about non-pharmacologic and like the lowest risk interventions that are available for any particular mental health or substance use condition. If somebody's already on a regimen of treatment that includes medication, ideally the preconception period is a time that a treatment team can come together and think about planning for pregnancy, planning for a postpartum period, planning for parenting. And when we're talking about pregnancy and we're talking about attempts to become pregnant, we also have to think about the impact of perinatal loss as well. Perinatal loss, which can include both early pregnancy loss, like miscarriage, later pregnancy loss, or neonatal loss, all can impact mental health. It can be associated with depressive symptoms, trauma-related symptoms, or frank diagnoses of PTSD, sleep disturbances, which are particularly important for thinking about risk on mental health. They can have pervasive impacts on the partner, whole family, and can also have impacts in subsequent pregnancies too. And so thinking about loss, it's important to disentangle the experience of typical grief, the sort of adaptive and human experience of grief from complicated bereavement, and also the role that potentially multiple losses or a series of losses can have, because depending on a person's health characteristics, this could be something that they face more than once in life. You'll notice as I'm talking, I'll be talking about perinatal mental health. And so that really refers to the entire perinatal period during pregnancy and the postpartum period. And much of this comes from the data that we have to support. There was a time when we were really focusing on the postpartum period as the time of greatest risk for mental health conditions, but in part that was the time where we were most likely to identify mental health conditions. In this study by Kathy Wisner and her group many years ago now, they did a postpartum assessment, both utilizing Edinburgh Postnatal Depression Scale questionnaires, and then further diagnostic assessment. And amongst those who were at 6 weeks postpartum, amongst those who had identified mental health conditions, when they were brought in for further diagnostic assessment, 2/3 of those individuals identified in the postpartum period actually had the origins of their symptoms during or even before pregnancy. And just to sort of continue the thread around screening and the utilization of measurements, it is recommended by many professional bodies that individuals be screened for depression and anxiety during the course of pregnancy, largely related to the fact that if we wait till the postpartum period, we're missing huge opportunities to identify, engage, and intervene around this incredibly important set of impacts. And so most recently of these professional bodies, ACOG, the American College of Obstetricians and Gynecologists, published practice guidelines recommending screening for depression twice in pregnancy and once in the postpartum period. But also just acknowledging or flagging that screening alone is not enough. So screening and identifying needs has to be coupled with systems that then ensure diagnosis, engagement in treatment, effective treatments, and then follow-up over the course of time. We recommend at MCPAP for Moms utilizing the EPDS, the Edinburgh Postnatal Depression Scale, which is a validated screening screening and assessment tool for use during both pregnancy and the postpartum period. Despite it being called the Postnatal Depression Scale, it has been validated for use in pregnancy as well. It is a freely available self-report questionnaire. So a person can take the questionnaire on their own. They don't need a provider to administer it to them. It is available in many languages. We have it available on our website and in our toolkits. And so it's something that we utilize largely because it helps. It's somewhat different than some of the other depression tools that are used kind of outside of the perinatal period, and it's particularly adapted to disentangle some of the physical complaints and physical symptoms and signs that are associated with the perinatal period from signs of emotional complications. You can utilize the score. It's out of a total of 30 potential points, and each of the items is scored with equal weight. And so a score can then be utilized to stratify risk of mild, moderate, or severe illness. And then once the scoring is complete, then sort of the goal or the idea is to then follow up with a clinical assessment. It's important to acknowledge that many of these tools that we have, unless we're thinking about the role that unconscious and structural bias can play, are not adequately impactful or are not impactful in the same way across multiple populations. So people of color, for example, are more likely to experience postpartum depression and less likely to receive adequate care. In the absence of universal screening, in fact, individuals are less likely to even be assessed for, individuals of color are less likely to even be assessed for mood or anxiety complications. In one study, African American and Hispanic perinatal individuals showed symptoms of perinatal mood and anxiety disorders at rates of 44 and 48% as compared to white women in that particular study in that population. And there's evidence of, even though once individuals are identified with symptoms of emotional complications, then the likeliness to be referred for treatment, the likeliness to actually be able to engage in treatment is in fact less among populations of color. So if we think about engaging in a process of screening, so then, we at MCPAP for Moms like to recommend essentially these 5 general steps to take after a positive screen. So when somebody's identified as being at higher risk for an emotional complication. The first step being assessing for severity and then assessing for comorbidities. As I mentioned, the screening tool itself can help with the severity piece, but then also we're thinking about asking about, doing a sort of more thorough evaluation of the specific symptoms, the exacerbators, the additional risk factors that can confer severity or higher risk. Duration, how often the symptoms are occurring, are they associated with hopelessness or helplessness, which are higher risk symptoms? Has there been treatment in the past? Is there a family history? Are the symptoms associated with a history of self-harm or psychiatric hospitalization? Is somebody having thoughts of self-harm or harm to others, including thoughts of harm to baby, which we'll talk a little bit more about. In addition to assessing current symptoms, it's important to assess risk factors. So if somebody has had a history of depression in their past, that is the #1 risk factor for them to have a perinatal depressive episode during any particular pregnancy. Having a specific history of perinatal depression or any other mood, anxiety, or trauma disorder also increases risk for experiencing a perinatal depressive episode. Having a family history of perinatal emotional complications, having birth trauma or a complicated birthing experience at that particular in the context of that pregnancy or a prior pregnancy. And this is one risk factor that I think we should all talk more about, which is that if a person has a history of any mood changes in the context of hormonal flux, including their menstrual cycle, be starting or stopping hormonal treatment, whether that be for contraception or fertility or for other indications, any emotional symptoms associated with that fluctuation in hormones is a predisposing factor to having a perinatal emotional complication. There are also non-reproductively anchored risk factors, including younger age or perfectionistic personality, historical or recent trauma exposure, psychosocial stress, isolation, the complexities of infant care in a postpartum individual. So there are data to suggest that increased crying and fussiness in the baby, lactation challenges, sleep disturbance associated with infant care, I should have put here, are all risk factors for emotional complications. Intrinsic factors to the individual, chronic medical conditions or even acute medical conditions, and then also exposure to racism. So we often talk about race as a risk factor, but really what we're talking about is exposure to racism and the experience of discrimination. When somebody is identified as being at risk or potentially having an emotional complication, it's important to think through what we in healthcare often call the differential diagnosis. So sort of thinking through mood disorders, trauma-related disorders, anxiety disorders, eating disorders, substance use, and medical causes. While the reproductive aged birthing population is generally less likely to have medical comorbidity or complexity, it's important to make sure that's being evaluated for, especially if somebody has new onset symptoms. And so important to engage healthcare providers broadly in somebody's treatment team. When we're talking about mental health conditions, it's always important to prioritize a conversation about safety. So we talk about suicide risk assessment, and we think about it in mental health care across a continuum, not just binary. So there's sort of this continuum of risk, lower and higher risk, with factors like having no prior history of self-harm or no present or current plan, intent, no concurrent substance use, the positive presence of protective factors, all sort of conferring lower risk on the suicide risk assessment continuum. And then on the opposite end, on the higher risk end of the continuum, a prior history of attempts, depending on the specifics of the attempts, the sort of quality of those attempts, how recent the attempt may have been, if the person has current thoughts about self-harm, intent to act on those thoughts, if they're having concurrent substance use, which can increase the risk for disinhibition and acting on thoughts. If there's an absence of protective factors or concurrent multiple sets of symptoms, all of those things can confer higher risk of self-harm. And then in this population, it's so important to talk about risk of harm to others, especially risk of harm to baby. It is actually quite common for individuals with perinatal emotional complications to have thoughts about harm coming to baby. The thoughts are most often associated with low risk, and they're in the context of the most common emotional complications: depression, OCD, anxiety disorders, or anxiety as a symptom. In that context, most people have good insight. They are quite troubled and perceive those thoughts as intrusive and outside of themselves and scary, and are not associated with psychotic symptoms or breaks with reality. And the fact that the thoughts may cause anxiety or discomfort, while we don't want our patients to experience distress and discomfort, the discomfort itself is actually a good prognostic indicator because it helps to distinguish these thoughts from thoughts that may occur in the context of a much more emergent and scary condition called postpartum psychosis, where it's associated with poorer insight into the the troubling nature of the thoughts. There are concurrent psychotic symptoms like hallucinations or delusions or paranoia, and that those thoughts may be part of a distorted sense of reality, sometimes an altruistic reality, but distorted and different from our reality. And so in that context, we are talking about very high risk thoughts of harm to baby. And that's a do not pass go. This is an emergency psychiatric evaluation, a Section 12 and emergency services mobilized situation. So as we sort of progress through what to do after a positive screen, it's important to have conversations about all treatment and support options. When we're talking about treatment, we're often talking about medications, but also psychotherapy. Individual psychotherapy is, in fact, first line for mild forms of emotional complications. Cognitive behavioral therapy and interpersonal psychotherapy are two forms of psychotherapy that have great evidence actually in the perinatal population, but we shouldn't forget about the role of group, couple, and family therapy as well. And fully acknowledging that it's challenging to access some forms of psychotherapy, we are here to help. I'll talk a little bit more about how to engage with us, but just to know that MCPAP for Moms, part and parcel of what we do is really to help individuals link to psychotherapy and other treatment resources. When we're talking about non-medication interventions, it's also really important to think about some of what we call sort of adjunctive interventions. So it's the role of social support, peer support, partner support, family support, self-care. So things like sleep and sleep hygiene, exercise, nutrition, hydration, and then mindfulness specifically deserves a particular call out because we have so much evidence about the wide variety of mindfulness practices and how they can be beneficial to individuals with emotional complications, especially in the context of the perinatal period, and as well as outside the perinatal period. But, we're also talking about kind of the whole spectrum of treatment, and medications themselves are an important part of treatment. Not always indicated, but often thinking about how and when to pull that tool out of our toolbox. Often it relates partly to the severity of the illness. Is somebody experiencing mild depression in the absence of suicidal ideation? They're participating in their roles like caring for self, baby, perhaps participating in work or other things, engaged in psychotherapy that's working. Then we may not think about pulling the medication tools out of the toolbox. On the other hand, if the symptoms are severe, if they're partnered with additional higher risk symptoms like suicidal ideation or thoughts of harming baby, you're not functioning well or caring well for self or baby, all of those things, then we really need to think about sort of adding on layers of intervention, including medication. And then when we're talking about treatment, it's so important to talk with our patients specifically about how they think about treatment and to do a little bit of myth busting too. When we're talking about medications, for example, for mental health, there's a lot of misperception. I mean, I can't tell you how many times I've had individuals come and see me clinically and say, well, I can't take anything because I'm pregnant. I don't want to, or I don't want to take anything because I'm pregnant. I don't want to do anything that could be harmful. And so this is an opportunity to say that, in fact, there are effective treatments, both medication and non-medication treatments that are available for use during pregnancy and breastfeeding. That depression is very common during pregnancy and the postpartum period because a lot of people, I think more and more as we're talking about mental health, this is becoming less mysterious that so many people are impacted by mental health symptoms, but it's still important to sort of say how common these symptoms are during pregnancy and the postpartum period. And, reminding people that their threshold for taking medication during pregnancy for other indications may be lower than for mental health reasons. And, asking them to sort of consider that. Why is that? And then reminding people of this very important concept of no decision in the context of pregnancy being entirely risk-free, and that there is an inherent risk in not engaging in treatment too, because then you're thinking about or needing to remember about the risks of the untreated illness that may emerge. And so sometimes we get so hyper-focused on the risks of the treatment that we forget that the illness itself carries risks too. So anytime we're talking about mental health conditions in the context of a perinatal individual, it is so important to specifically pay attention to the potential for bipolar disorder. And that is because bipolar disorder itself carries such significant potential differences in how it's managed, but also in particular risks in the postpartum period if left untreated. And it's also important to note that in the context of the perinatal population, bipolar disorder is actually more prevalent. And so individuals, even with depressive symptoms, in that same study I described earlier, sort of defining perinatal emotional complications, Dr. Wisner and her group, when they did further diagnostic assessment of those 10,000 postpartum individuals, upon further evaluation, almost a quarter of those who had depressive symptoms did in fact meet criteria for bipolar disorder. And it's so important to really think about identifying bipolar disorder early because it really changes the way we manage, especially in the context of medication. So prescribing an antidepressant, for example, to somebody who has a bipolar illness can actually worsen outcomes. And so we just want to be thinking about identifying as many cases of bipolar disorder as we can early. Also because unstable bipolar disorder or untreated bipolar disorder going into the postpartum period also predisposes that individual to postpartum psychosis, which is again, a very scary condition that occurs in about 1 in 1,000 postpartum individuals, is highly associated with bipolar disorder, but not all cases of psychosis occurring in the postpartum individual are associated with bipolar disorder. But when it emerges rapidly, sometimes within 24 hours of delivery, though can be as long as weeks after delivery. It can be associated with mood symptoms, psychotic symptoms, a confusional state or disorientation that can look like delirium. It is a psychiatric emergency, though, because of the rapid evolution, because of the high association with harm, including infanticide and suicide. So this is a condition we want to do everything that we can to try to prevent by addressing early, by trying to identify those at risk early, utilizing both depression screeners and then also specific screening tools for bipolar disorder. So in our training materials, which are available on our website, in our toolkits, you'll find a couple of different examples of how to screen for bipolar disorder. We have the mood disorder questionnaire, which is similarly it's self-administered, handed to a patient and they're able to answer the questions on their own. So that's one option. And another is we have called it's the CD, and it's also in our provider toolkit, and it's a sort of series of questions that essentially ask some screening questions for the presence of mania at some point in a person's life. And so you'll find those in our toolkits, and there will be links at the end of the presentation and our slides that are available in terms of how to access those. In thinking about bipolar disorder, once it's identified, just to sort of underscore that preventing decompensation is critical. Medication is a key part of that, as well as thoughtful birth plan that is trauma-informed and focused on sleep and well-being of the birthing individual, and then also places a focus on the caregiver-infant relationship. It's someone with bipolar disorder requires close monitoring, close collaboration with pediatrics, a thoughtful plan about that postpartum period that supports feeding and sleep, and limits stress. And then also we're thinking about the fact that bipolar disorder is highly recurrent and will require management across a lifetime. So, if I haven't scared you enough, bipolar disorder is serious, but it can be addressed. And so once we've sort of thought about all of these factors, then we're really trying to think about how do we engage in the risk-benefit discussion about treatment. So just a reminder of the sort of cardinal principle in thinking about treatment. There is no such thing as no exposure, no risk-free decision, as we often say. So we need to be constantly holding in balance the risk of the treatments that we're proposing or that we're considering for a particular person alongside the risk of the untreated depression or other emotional complication. And it's a continuous balance. And so sometimes it involves really kind of thinking about how do we strike a balance between the fact that any treatment that somebody engages in may have some risks. And so we use some general principles at MCPAP for Moms, and we'll often talk about these in our phone consultations or in our direct patient evaluations when we're evaluating patients. There are some sort of general principles we think about in the context of a pregnant or lactating individual. Using what's worked before. So if we have if we are able to gather enough history to get an adequate treatment assessment, or his treatment history rather, we're able to think about what are the things that are most likely to work again. When we're thinking about how do we dose medication, we're thinking about the lowest effective dose. Again, one of these common questions that we'll hear is, what is the pregnancy dose? What is the dose in pregnancy? How do you adjust a medication dose specifically for a pregnant individual? The point we always try to underscore is we want to give the most effective, the dose that's effective at the lowest potential exposure. But the most important piece is the efficacy. So there isn't a pregnancy-specific dose. Broadly, it's really about what has been the dose that's been effective for that individual. Then we're also trying to hold in mind the other goal of trying to minimize total number of exposures to differing agents. And so we want to think about minimizing switching from medication to medication, minimizing polypharmacy, trying to think about monotherapy or single medications to address more than one concern when possible, or the fewest number if a single medication isn't possible for that particular individual. And then, as much as we are thinking about the lowest dose, we also need to be continuously mindful of the fact that pregnancy and the postpartum period are dynamic states. These are states where these are states that involve kind of a gradual change in physiology and metabolism that change over time. And so actually we're seeing a need to often increase dose to match those changes as pregnancy advances, which can sometimes be at a bit of a surprise for patients sometimes who are thinking about, I want to take the lowest medication dose possible. And we'll say, well, yes, but we want to also be making sure we're matching your changing physiology and the changes that are happening in your body. And then another really important principle that we often find ourselves at MCPAP for Moms talking about and underscoring is that we really want to discourage this practice of discontinuation of medications that people are stable on upon the emergence of the diagnosis of pregnancy or discovery of pregnancy or in anticipation of delivery. We see this so often where individuals, upon finding out they're pregnant, will stop their medications and then come to prenatal care with unstable mental health symptoms. And then we're in the process of trying to reestablish treatment. And so part of our goal is to really try to discourage this practice. And some of that is prior to people engaging in prenatal care, and that's the work of primary care and mental health providers to do. And some of that is for us, all of us who are working directly with the perinatal individuals. In the interest of time, I'm not going to drill down specifically into all of the data for all of the different medications, but really just to talk about kind of broad strokes. Antidepressants, which are the most commonly prescribed medication to perinatal individuals and are widely studied at this point. We now have studies that in total have looked at hundreds of thousands of participants over the course of many years. And we can confidently say the absolute risk of birth defects associated with antidepressants, especially with first trimester exposure, which is when we think about the potential risk for birth defect, the absolute risk is small. Now, there are some inconsistent data for some agents, including paroxetine or Paxil, but upon the whole, we really see an overall low risk of birth defects. And so that is meaning over the sort of baseline rate of up to 3% for all individuals, kind of irrespective of exposures. Any utilizing any antidepressant in the context of pregnancy does expose the neonate to the potential emergence about 30% of the time to transient self-limited adaptation symptoms that we can call some that are, it has different nomenclature: neonatal adaptation syndrome, poor neonatal adaptation. This is a self-limited syndrome without lasting developmental consequences. There's no data actually to support that these symptoms are reason enough to discontinue medications. The symptoms are treated with supportive interventions like soothing and skin-to-skin contact and all of the things that are otherwise done, and it generally lasts less than a week. There is a tiny increased risk of persistent pulmonary hypertension of the newborn, though with further evaluation as we get better and better data, the elevated risk over the general population is perceived to be even smaller. There is also an associated small increase in risk for preterm labor and lower birth weight, though that absolute risk is actually about the same magnitude as that of untreated depression. So it really is not a risk that we necessarily would change the way we approach treatment for. And with better and better data over the past decade, we really can comfortably say that the studies are not suggestive of long-term neurobehavioral effects for children who are exposed to antidepressants in utero. There are some emerging new treatments that have emerged over the past 4 to 5 years that are really exciting, actually, in the context of thinking about treatment for mood disorders broadly, but especially for perinatal individuals. The first kind of, at the time, it was an orphan drug with a new mechanism of action, different from the antidepressants we've been seeing for the previous decades, was called brexanolone, or the brand name Zulresso, which was an IV infusion that occurred over 60 hours and really implemented a different approach to targeting treatment that specifically had relevance to the perinatal individual because it addressed the impact of reproductive hormones. So allopregnanolone is a metabolite of progesterone. And so it really had a particular approach that was relevant to perinatal individuals. It being an IV infusion, and for a variety of reasons, including its emergence at the beginning of global pandemic, made it a relatively hard medication to implement. But recently, in the past year or so, we have seen zuranolone, which is an oral formulation of a medication that is has a similar mechanism of the same mechanism of action, but is now able to be taken as a once daily oral treatment across a 14-day course, and has really, I think, offered patients who we were often saying you have to wait weeks and weeks for medications to work, really an opportunity to experience a much more rapid relief from symptoms. As we think about treatment outside of just depression and antidepressants, we also have to think about mood stabilizers, as we've talked about for bipolar disorder. There is really a complexity to thinking about mood stabilizers in pregnancy that is a little bit outside the scope of what we can talk about. It requires probably a whole other hour just to talk about. But again, we think about things across a sort of continuum of risk. And so there are no 100% absolutes, but we really think about like some medications being extremely risky in the context of pregnancy, others with more emerging data or reassuring data, and others with lower risk. And we really try to think about, for a particular individual, where does their individual history intersect with the data that we have available? When we're thinking about a lactating individual, breastfeeding itself should not preclude treatment with any psychiatric medication, frankly. With all medication, is all about relative risk. So we're thinking about the relative infant dose, meaning how much medication that's taken by the adult is then passed into the breast milk So what proportion is present in the breast milk? What is the data of that we have available on the effects of that medication on infants who are fed that breast milk? And then what is the impact of any particular treatment or medication on lactation itself, the function of lactation, milk supply, for example. And it's important to note that actually breastfeeding medicine and the science of lactation is actually not well studied. And so most of the data we have is based on case reports, very small numbers, very totally uncontrolled data that is highly individualized and confounded. And so we're really operating with relatively flawed or sparse in scientific information. And so we're really having to think about how do we collaborate among as care teams, and how do we integrate what is known about these particular medications alongside what's known for this particular individual. So it's all about relative risk and careful and nuanced decision making. When we're thinking about medications for a lactating individual, we most often recommend sertraline or Zoloft amongst the antidepressants, but there are a few listed here that are relatively low in breast milk. Similarly, with the mood stabilizers, we have kind of another continuum. These arrows, again, just to sort of say we're always talking about relative risk. And so I'll just transition now, just in the interest of time, to talking a little bit about substance use in individuals. There are a few interesting things happening within our state and overall thinking about perinatal substance use. But most importantly, I think to underscore is that individuals with substance use and substance use disorders can really present at any point in the perinatal period. So I've had individuals come at the first prenatal care visit and tell their provider, I have a substance use disorder. I've been stable for XYZ amount of time. I take these medications, and I'm looking forward to moving forward with prenatal care and a healthy delivery. I've also experienced referrals from my colleagues regarding a patient who has given birth, and there was a substance use disorder is part of her context that was totally unknown until the baby was born and had withdrawal symptoms in the NICU. And so there's this kind of wide way in which individuals can present. And substance use itself is a complicated context. It is a hard to treat illness that's laden with stigma and shame that the impacted individual brings. There are legal issues that we as a system are grappling with. We as providers have to be clear about our own biases and emotional reactions. Individuals who present with substance use often present later in their pregnancy, and so we have a constricted window of time to help intervene. And there is limited access to subspecialty care for perinatal individuals. As mentioned before, opioid overdose is a leading cause of maternal mortality. These are specific data from our state and our DPH, Mass DPH, looking at kind of the rates of overdose. And there's a couple of important patterns that I just want to highlight here. And that is that overall, during pregnancy, there is this kind of window of opportunity where rates of overdose decrease, likely because rates of use decrease. And then there is an acceleration of risk in the postpartum period. So in the 6 to 12 months postpartum, we see an escalation in risk. So we have this kind of window of time where we can intervene. And the other piece of it is that medications for opioid use disorder save lives. And so when we're thinking about the abysmal maternal mortality trends that we see in our country, we have treatments and we have mechanisms that we can think about to help address that and turn the tide a bit. But when we're thinking about opioid overdose, these are, again, data from our state. We have to think about that there are differential impacts amongst populations and communities of color, and we have a lot of work yet to do. This is, again, just to underscore that substance use in pregnancy diminishes specifically during pregnancy and then accelerates in the postpartum period. A couple of just sort of plugs for what we at MCPAP for Moms can offer. We do have a toolkit that was specifically created to help facilitate substance use treatment providers and OB providers who are working with individuals with substance use. And within it we have a couple of tools for thinking about the language we use and how we can prioritize strength-based, person-first language in a non-stigmatizing fashion. So just a plug to check out our toolkit for some tools like this. When we're thinking about substance use in the perinatal population, we're again thinking about the role for screening. Universal screening is recommended by many professional organizations. We at MCPAP for Moms recommend a modified version of the NIDA quick screen in OB settings, but there are actually a number of different tools that are available, and we're happy to talk through. Again, our toolkit offers a number of different strategies for thinking about how to assess substance use in pregnancy, including the role for toxicologic testing. When you are engaging in a screening process, as we talked about with mood and anxiety disorders, screening is using questionnaires is part of an assessment, but then there's history, physical examination, looking at the prescription monitoring program, and also understanding the role of toxicologic testing, which is an area in our state of rapid change. Toxicologic testing can have major impacts on an individual. The data can be utilized in a variety of ways, including having significant legal implications. And so it's important to distinguish issues around maternal and neonatal testing and the role the data may have, gathering adequate consent and having clear understanding of hospital policies about indications for testing, and then the characteristics of the tests that are being utilized at a particular hospital, because they vary widely. And so a couple of major health systems now, large health systems in Massachusetts, have really started to shift their policy around indications for toxicologic testing and the role of reporting, for example, to DCF. And so this is an area of active change that's having major policy implications in our state. So more to follow probably in the next few months, but just to flag that for any individual with substance use disorder who's seeking care, it's important to just think about the context within which they're delivering. This is just another screenshot of something out of our toolkit. And then another update is just to say that pregnant and parenting people with substance use disorder really benefit from collaborative care. And there's a mechanism in many states, including our state, to engage in a process which is essentially a way to document the collaborative team of providers that may be present for a particular individual, and it's called the Plan of Safe Care. This is another area of active change in our state. So myself and some other members of our team and other amazing individuals across our state are involved in a collaborative, in-depth review of the process of implementation and utilization of this, has been called Plan of Safe Care, including definitions for who it applies to and the policies that are linked to it. The nomenclature is likely to change soon to be called a family care plan, and the pathways within which we're utilizing data generated by this Plan of Safe Care, including when reported to DCF, are all being examined very closely and highly prioritized by leadership at DPH, within DCF, and the Office of the Family Advocate. And so I'm really excited to sort of see what comes in the next year, because there's an immense amount of effort after years of calls for change. So I think we have a little bit more to be seen. So just in the last couple of minutes, I just want to underscore, how can MCPAP for Moms help? We are a service that is freely available to any provider who is working with a perinatal individual with mental health or substance use conditions. We're available Monday through Friday, 9 to 5, through our 855 line. We offer trainings on, so if there's any of the topics that I've sort of just mentioned by way of overview today are of interest, if you think you're team would be interested in having a more in-depth training, we do them for free. We can do either in-person or virtual trainings. We also do real-time provider-to-provider phone consultation on our 855 line. And we have a team of resource specialists who are able to help with connection to mental health and substance use treatment resources, who can call pretty much any type of provider working with a perinatal individual. So ranging from obstetric providers, who are our most common caller type, to psychiatric prescribers, primary care providers, pediatrics, substance use treatment providers. I will say over the years, I've gotten calls from emergency rooms, from correctional facilities, from inpatient psychiatric settings, really. And if you have a question and you think that talking with a perinatal psychiatric expert would be helpful, we are here to help. So that's really kind of the last piece of what I wanted to say. We have a website with lots of resources, including our toolkit. And then at the end of the presentation, when the slides are posted, there's other resources. So hopefully we can have a time for a few questions at the end. I tried to be parsimonious with time to be able to make time for questions. Are there any questions in the chat, Beth? Or
currently no questions in the chat. And people are also welcome to raise their hand, and we can unmute you if that's preferred.
And just because I'm having trouble with Teams, can you just confirm, have I stopped sharing?
Yes.
Okay, thank you. I see something in the chat.
Lots of thank yous. The question is, can you provide us with a copy of the presentation? And I can actually answer that. Yes, we will have the slides as well as a recording posted to our website. Usually it takes us about 24 hours to get that up there.
I think I see a hand raised.
All right, this is from Sabrina.
You can just go ahead and unmute.
Yeah.
Okay. It wasn't giving me the option before. Hey, I'm an adult psychiatrist working here at Northeast Health Services. What is your understanding of zuranolone, and in your experience, how is it helping? Just a little information on that would be helpful.
So I will, in full disclosure, say I actually have not yet personally prescribed zuranolone yet, though I've been involved in the care of a couple of people for whom we've considered it, who are either in the process of pursuing it for or have had it. And I will say that there are a couple aspects to zuranolone that I think are both that are in the pro section, and a couple that are a little bit some challenges. The pro is, as I stated earlier, the potential to really avail individuals for rapid access treatment is a game changer, especially when we think about sort of the challenges of accessing care, the challenges that symptoms can have on a perinatal dyad or a family, and the duration of symptoms. So this rapid access change, I think, is really rapid relief is a game changer. It is a little bit hard to access, though, and partly because making sure that in insurance and prior authorization that may be required, like they're so variable that, where zuranolone falls on formularies is still kind of being worked out. And then also it has to be accessed via essentially three potential specialty pharmacies that then hand deliver to individuals' homes directly this medication, and then it has to be taken in a very kind of prescribed way where it's like daily dosed with a dosing pack. So then the sort of logistics are a little bit challenging, but from what I'm seeing and hearing from colleagues, it's definitely been effective. People are experiencing positive outcomes and relatively minimal downsides.
Very nice. Thank you so much.
Great question.
We have another question that came in. What do you do about women with SUD that want to wean in pregnancy?
So I'm assuming what you mean by wean is meaning taper off of treatment or taper off of the substance that they're misusing. Maybe the person who, well, I'll start first with treatment. So generally speaking, depending on the particular substance use disorder we're talking about, we tend to limit or we tend to discourage stopping agonist therapy. So meaning if somebody has an opioid use disorder and they're taking methadone or buprenorphine, if they have an alcohol use disorder and they're taking naltrexone, for example, these treatments that are sort of thought of as like maintenance treatments, we tend to try to limit the alteration in what has kept them stable and well because of the risk of relapse. And because as we get more and more data about the potential risks of opioid withdrawal, which sometimes are a factor of like agonist treatment, for example, with opioids like methadone and buprenorphine, we actually have come to learn that the withdrawal itself is relatively is manageable, whereas the risks of an unstable substance use disorder have much greater potential impact, including fatal impact. And so we tend to try to discourage people tapering. If somebody has a strong preference towards tapering off of medication, we really try to focus on a very sort of a harm reduction approach, gradual, low and slow, very, very incremental taper to limit the exposure to the pregnancy to withdrawal symptoms and also decreasing the risk somewhat for relapse.
So you wouldn't want to switch to Subutex from buprenorphine or Suboxone?
During pregnancy, we would not recommend switching. This is like a conversation that we could probably spend like 20 minutes on alone. But generally speaking, if somebody's stable on a medication, it's totally the right thing to do to just keep them on the medication they're stable on. If somebody's early in pregnancy and they were taking Suboxone, for example, and you have the ability to switch to Subutex or single formulation buprenorphine, it's an option. But it's challenging. And sometimes the challenges are actually more harmful than just remaining stable, because we have a lot of good data to say that just stably maintaining somebody on the treatment they're already on at the beginning of pregnancy is the better part of valor with lowest risk.
Okay, thank you. And plus, it's usually the 3 to 8 weeks, right, with the systems development and the neonate. So it's like less risk once they're in the second trimester or third trimester to make and the need to make the changes at that point. So we'll just keep them on the previous med.
So generally speaking, yes, we worry about teratogenic risk in the first trimester. However, the medications for substance use that we're talking about are actually not associated with increased risk for birth defects. So it's kind of null or like a moot point specifically for that context. But yes, like a lot of worry decreases when someone reaches the second trimester. But buprenorphine, methadone, naltrexone, none of these medications are clearly associated with increased risk for birth defects, even with first trimester exposure.
Okay, thank you so much.
And then we have one last question, and I know that we're at time. Would you recommend tapering benzo early in pregnancy for patients who have been prescribed long-term prior to pregnancy?
So I very intentionally did not mention benzos because it is a very complicated and nuanced conversation. So that's why I'm smiling, is not because it's not an excellent question. Benzos are very widely used, but they are really complex medications to manage. Benzodiazepines taken during pregnancy do predispose the neonate to withdrawal symptoms and to a need for increased monitoring at the time of delivery, potential for respiratory depression, hypotonia, or floppy baby syndrome. So they're not a benign exposure, but also the conditions they treat are not neither are they monolithic, nor are they easy to tackle. And so it can be a really complicated conversation. But one thing we do not recommend is taking away something that has been used for treatment and not having a strategy to address the underlying condition. So I think that's like the absolute here is if somebody is utilizing some form of treatment, it's really important, ideally, to have a very planful approach about what, if something's going to change, what is going to sort of come in to supplant that change. But it can be really hard to disentangle someone from chronic benzo use. And so it's something that there's not a one straightforward answer to that question. And call us if you ever have a specific case you want to talk about with these questions. These are definitely conversations that we can have one-on-one, taking into account the specifics of a particular situation. That's what we're here for.
Well, thank you so much. This has been a really great presentation, and thank you for everybody for joining us today. A survey will go out shortly, and we always appreciate your feedback.
Thanks to everyone who came. Lots of familiar names I see.